Hi everyone, I'm Dr. Narjust Duma. We're going to talk about the unique aspects of cancer care in the Hispanic and Latinx population. Before we start, it would be important to describe these two terms, Hispanic and Latinx. So Hispanic comes from people that speak Spanish as their native tongue or primary tongue. This includes people from Mexico to Argentina and also patients or people from Spain. Latinx, Latino or Latina, they're from Latin America. It means the geographic location that is from Mexico to Tierra del Fuego, which is in between Argentina and Chile. So Latinos in the United States are one of the fastest growing population. Are expected that 55 million people in the United States self-identify as Latinx, Latino or Hispanic. These two terms we use we interchange the terms during the presentation. It's expected that Latinos right now are 17% of the population in the United States, but by 2030, this number is going to significantly increase to around 20 or over 20% of the US population, meaning that by 2030, 1 out of 5 people in the United States will self-identify as a Latino or Latina. Currently, 1 out of 4 children in the United States is Latinx. So cancer health disparities are various differences between certain populations, and we're gonna focus on the Latinx population in this talk. Incidence is different, stage of diagnosis, mortality, survivorship, screening rates, and access to clinical trials are all part of the spectrum of cancer health disparities for the Latino population. There are many more others that we continue to study and determine. So one important aspect of cancer in the Latino community are social determinants of health. Social determinants of health are factors that access to care, economic opportunities that are related to your health. Resources in homes, schools, neighborhood, and communities. All of this together represents social determinants of health, and we determine how your health will be independent of your biologic factors. Do you have access to primary care? Do you have access to cancer screening? All of those are important parts, and education tends to be a very well known and very important part of cancer health disparities in the Latinx population. Into education, we include language barriers. So let's talk about specific aspects of the Latinx population in cancer. So 1 in 3 Latinx will be diagnosed with cancer. 1 in 5 Hispanic men likely will die from cancer. 1 out of 6 Hispanic women likely will die for cancer. And Hispanic women in the United States, living in the United States, are twice most likely to die of cervical cancer compared to the majority group. And as you know, cervical cancer can be considered to be a disease that is preventable not only with the HPV vaccine, but also with regular pap smears. So cancer in Latinos is where we're gonna focus, but this is a call to action. The problem has been described many times. The problem of lack of access, the problem about not being included in clinical trials, all of that has been reported already. So the goal of me talking to you today is how you can help us improve these outcomes. So in the next 10 years, Latinx are expected to face 142% rise in cancer cases, 142%. So things are not gonna get better, things are only expected to get worse. So the US Hispanic population, we talk about this, about the 17%. The majority of Hispanics or Latinos are located in states like California, Texas, New Mexico. The fastest growing counties for the Latino population for 2007 were located in locations that are not expected. The top 3 are in North Dakota, that could be related to immigrant workers, also in South Dakota, Utah, and Alabama. So there are higher rates of cancers in Latinos that are associated with infectious agents. For example, liver and hepatitis, stomach cancer or gastric cancer and H. pylori, and cervical cancer and HPV. There's one phenomenon that I want to describe to all of you, and it's called the Hispanic paradox. The Hispanic paradox has been evolving over time. So the Hispanic paradox comes to the fact that the immigrant Hispanics or Latinos, it means the first people that migrated to the United States, despite having limited access to healthcare, despite having lower educational levels, they do better with cancer compared to African Americans and Hispanic and non-Hispanic whites. But the Hispanic paradox changes as the next generations come. So the first and second generations of Latinx that are born in the United States, they are less likely to benefit from the Hispanic paradox, and these numbers tend to match the African American group or the Native American group that already have significant disparities. So the Hispanic paradox applies to people that has recently migrated, and also known as the healthy migrant effects, and is associated with several factors. The person that just migrated are less likely to have an unhealthy diet, a diet that's very common to what they used to eat at home, which is high concentration of fruits and vegetables. And also there's a community in which is the support of the community tend to help the outcomes. But the assimilation is what is making our Latinos sick. We talk about the social determinants of health and how low socioeconomic status, obesity in children, high insurance rates are associated with the disparities in cancer care in Latinos. Latinos, Latinas, and Latinx are the group with the highest uninsured rates in the United States and the group that benefit the most from the Healthcare Act. And there's only a few of the social determinants of health that exist for our Latinx population. So let's talk about what is more common. So we talk about the cancers that are more common, including cervical, stomach, and liver. But cancer is the leading cause of death among Latinos, accounting for 22% of the death in Latino population. One of our studies that we presented in the first meeting about cancer in Latinos in 2018 shows that being a Latino decreases the chances of you being referred for a palliative care consultation. Only 2.2% of patients with metastatic lung cancer were referred to palliative care. And multiple studies have showed that referral to palliative care for patients with stage 4 lung cancer improves not only survival, but also the quality of life. So that's a big barrier for Latino patients, is that they're not getting referred to palliative care. One challenge about Latinos is that Latinx and Latinas and Latinos and Hispanics, they're all grouped in one name, but we're actually very heterogeneous. We tend to have a lot of genetic background that it changes from our geographic location. For example, is the Latinx that come from the Caribbean tend to have a higher prevalence of African genes compared to other groups in South America, in which they have more a European background. But we're all lumped in this big group called Latinx. And I think seeing Latinos as a big group is a challenge for cancer care, because we need to understand that the belief and perceptions of health changes based in the geographic background where the person came from or where their family came from. So advancing the science of cancer care in Latinos, it needs to be based in inclusion research, in which we include all groups of Latinos. One example of this is a lot of studies are based in California and Texas, in which the majority of the immigrants to that area are from Central America, and we may inappropriately extrapolate that information to all Latinos. So something that I was involved early in my career is the Fortaleza Latina project at the Fred Hutchinson. So this study was focusing on improving breast cancer screening for Latinas in the state of Washington. And they partnered with a local clinic called CMAR in order to reach the Latinas and provide follow-up and interview them about the perceptions of breast cancer screening, because the perception is very different based on the generation, the geographic location, are the from Central South America are from the Caribbean. So having things that are tailored to this population are very important to advancing the science of cancer care and Latinos. One important aspect before we move forward is to talk about race and ethnicity. While this may be a controversial topic, race is a social construct. It has a biologic background in which we have certain genes that may put you at higher risk for certain aspects, but are the social aspects of race that are the main reason of the health disparities that exist. Not only for Latinos, but also for African Americans, Native Americans, and other minority groups. So the aspects of social construct are those social determinants of health that we talked about earlier, right? And there's a difference between ethnicity and race, and this is very confusing for many Latinos, including myself. So being a Hispanic or no is an ethnic classification. So do you self-identify as Hispanic, yes or no? And then there's attachment of race. And that can be very challenging because the categories for race tend to be very binary, not binary, but very strict. And then you have to self-classify as Black, African American, or white or Native American, and ethnicity is attached to that. So there are two concepts that are related. So first, race is a social construct. Second, ethnicity is related to your being a Hispanic or not. It means, do you speak Spanish or do you come from a family which main tongue was Spanish? And race is the aspects in which you also self-identify. So cancer health disparities, as we talk about it, there's several. And I'm going to talk about some things that I have been involved with and that I think we help us move forward. So this is my grandma. So my grandma, or my abuelita, is 86-year-old. She is a lovely woman, but she always taught me that when you mention a problem, you need to come to her with a solution. And this comes to the fact that if we were talking about the inequalities in cancer care for Latinos, we need to bring solutions too. It is time for action. We have determined the inequalities that are there. I have documented it. Many research have documented this. And it's time to move forward. So we're going to talk about a challenge, and then we're going to talk about a potential solution. So the challenge, one of them is that there is very inaccurate classification of Latinos. And this comes to the aspect that we talk about race and ethnicity. Many Latinos are confused what to select, and that reduces the quality of the data. Also, not everybody's familiar with the subjects, and when you do the research based on poor data, you will get poor outcomes, poor quality outcomes. And sometimes there are studies that classify Latinos based on their last name. And as you know, last names switch based on marriages and based on many other aspects. So data collection is poor for race and ethnicity in the Latino community, and is also associated with poor collection with other minorities, like sexual minorities, patients that are different sexual orientation and gender minorities. And this is an example of a study done by Dr. Kathak Rake, who's a close friend, talking about that out of over 380,000 cases, only one patient was self-identified as transgender. And as we know, those are no data that we correlate with reality. So a few suggestions is to make sure that all research, all large databases collect a standard set of race and ethnicity and social demographic aspects. If we all ask the same question, we have uniform data. Also, it's important that race, ethnicity, sexual orientation, and gender identity is collected by all researchers and no clinical settings. So it has to be part of clinical trials report. It needs to be part of all the studies that are being classified because it's important for outcomes and it's important for us to understand and improve the quality of the data. So I think one of the things that we were just talking about is how studies have happened in asylums in the United States. So a lot of studies in cancer care in the Latinx population happen in Texas and happen in California and New Mexico and Arizona. We tend to have a higher percentage of Latinx patients. But we tend to generalize those results to all the Latinx populations, which are different. If you're able to have a few minutes, just go back and try to find out the immigration and migration patterns of the Latinx population. One example is Cubans and Venezuelans tend to migrate to South Florida. Dominicans and Puerto Ricans and Cubans sometimes migrate to the Northeast, New York, New Jersey, Philadelphia, Pennsylvania, or Connecticut. Then there's a high migration of Central Americans to the southern parts of the US, like Texas and Arizona. As we know, that used to be part of the United States. So some people they haven't migrated, that's their background. And we also, that used to be part of Mexico, not the United States. And there's a selection bias. We are surveying the Latinos that are most likely to participate, but the selection bias is very strong. So we tend to use single databases versus large databases. And here we're just gonna talk a little bit about the strengths and the weakness of this. So the benefits about the single institution studies is that you have very detailed information. You can capture individual socioeconomic status, you have a close follow-up, but you have referral bias, right? Are you comparing the information from a large cancer center, an NCI cancer center in a very large city, or are you comparing the data from rural Wisconsin? So I think it's challenging to make these small studies, but they give you more details. The problem is with the large databases is that we talk about is the misclassification of Latinx, in which they may be misclassified as Black, but they're Hispanic Black. So I think when I look at race and ethnicity for the Latinx population, it should be seen as first name and last name. So your first name is your ethnicity, so Hispanic or non-Hispanic. And your last name is your racial background. Are you self-identify as Black, white, more than one race? So the problem with the large databases is also the lack of follow-up. So there are multiple challenges that we can do this, and I think a multi-level approach is recommended, and that we see other aspects of cancer care for the Latinx population just beyond stage. We need to pass stage. We also lack significant representation of Latinos in biobanks. There are biobanks of hundreds of patients that only have a handful of Latinx patients. So when we're making conclusions about this gene being more common here or there, we don't really have the samples for the Latinx population. And we still don't know interactions about a lot of risk factors. So a potential solution, I think I use the African American Breast Cancer Epidemiology and Risk Consortium, AMBER, that have been a successful program to try to recruit African Americans and Blacks to understand the natural history of breast cancer in this population, and this could be a solution for the Latinx. Also, we need to prioritize, and large institutions need to make sure that it's mandatory, and also the funding agency, that is mandatory that minorities, Latinx, are included in all genomic studies. And that the sample is representative of the US population. So if the Latinx are 17% of the population, it's expected that 17% of your sample should be Latinx, in order for you to have general results. Otherwise, you are just talking about results for the majority group, and they shouldn't be extrapolated to the Latinx population. Another thing I think is doing studies that are tailored to the Latinx population. One of these is the COMIDAS study. The COMIDAS study is a study from the Fred Hutchinson as well that tries to evaluate the interactions between environment, biologic, and cultural factors and the risk for cancer. One study that I recently published is the effects of socioeconomic factors on treatment decisions in non-small cell lung cancer. Surprisingly, in this study, we found that socioeconomic factors were the detrimental part for patients to refuse treatment for a stage 4 non-small cell lung cancer. As we know, patients with non-small cell lung cancer that don't get treated have a very short survival. In addition, the treatment of lung cancer has changed in the last 10 years. And secondary to that, the survival is significantly improved. So I think it's very important that we take that into account when our patients are making treatment decisions. Add Are or Latin Hispanic patients making treatment decisions based on the concerns about insurance, based on the concerns of copays, or based on the concern also that they're going to leave a big debt for their family? And I think it's important that we ask our patients when they refuse treatment, what is the thinking behind it? And also there's an aspect of medical education and health literacy that needs to be addressed when a patient from a Hispanic or Latinx background refuses treatment. And here you can see Anil's highlight of the study that shows that socioeconomic factors, not race or ethnicity, were linked to treatment refusal for advanced lung cancer. So in our study, we found that it was the insurance status, the socioeconomic status will determine if a patient will refuse therapy and not their race or ethnicity. So another big challenge is that we are not recruiting Latinx in clinical trials in cancer. This is a publication of us from 3 years ago, in which we show that over the 14 years, instead of improving the recruitment of Latinx in cancer clinical trials, we're actually doing worse. So this was actually very striking. We saw the same in multiple myeloma with African Americans. And when you get a patient in a clinical trial, the patient has the opportunity to get access to treatment very early on, and they may live longer. So one of the big challenges about inclusion of minorities and Latinx and Hispanics into clinical trials is that many of them have Medicaid, particularly the patients that are less than 65 years old. So at this time, Medicaid does not, Medicare and the majority of the states are no mandatory to cover the standard of care when patients are participating in clinical trials. So if you're trying to enroll a patient in a clinical trial, usually the sponsoring company, the sponsoring cooperative group or institute, we pay for the experimental drug and the treatments that are outside of the standard of care. But in the case of Medicaid, they're not forced to do that. Medicare does it. But the challenge with this is that then we are excluding the patients that have Medicaid, and the majority of those are Latinx. As we talked earlier, they're the highest onshore population in the United States. So ASCO is participating in large advocacy efforts, and I had the privilege to do this 2 weeks ago, in which we did a virtual Hill visit. We had done it the year before, in which we are advocating to our lawmakers to try to make Medicaid mandatory to cover the standard of care so we can include these minority populations in clinical trials. It's not only about having good data, it's about giving patients the opportunity to get these treatments. So other goals is to liberate the inclusion and exclusion criteria. African Americans and Latinos are most likely to have comorbidities like diabetes, and these very tight inclusion criteria tend to exclude many of these patients. Also to have target accrual goals. If the NCI is sponsoring the trial should be an accrual goal based on the sites of recruitment. I think it's very disappointing when studies are conducted in states in which the majority of the population are Latinx or Hispanics, and they barely have a Latino patient. So I think making it mandatory should be very, very important. And also expanding clinical trials to community hospitals. As we know, Latinx populations are more commonly treated at community hospitals. And the most important aspect is that there's provider bias. There's a provider bias that Latinx patients will not agree to be in a clinical trial, and there is no data that backs that up. So it's important that we ask our patients and we give them options, educated options, or how a treatment or a clinical trial will be beneficial or risky. There's a mistrust, not only with the African American population, but also with the Latino population. And I think it's a mistrust based on real facts and real events. We encourage everybody to read about the anti-conception challenges and the anti-conception discrimination it took happen in Puerto Rico, which is part of the United States, in which these women were given the pill without having a full informed consent. And why some of the data have in this slide is controversial. The data about what's happening in the immigration detention facilities is still very challenging to understand what is true and what is not. But it's concerning that the patients are not getting the treatment they need, and then that just feels into the mistrust into the healthcare system. Will you trust a healthcare system that is hurting your sisters and brothers? Are we asking too much to our Latin patients just to trust us? When we continue to damage that trust with situations like the immigration detention facilities. Another challenge, I think, is the physician belief that un poquito de español is enough to describe cancer treatment. And that is not true. It is very challenging to talk about cancer treatment when the patient speaks the same language that you do. But when you try to explain something in a very broken Spanish, it's high likelihood that the patient will not understand. And that's when the challenges come and the bias that, oh, the patient is poor compliant. Is the patient not compliant because he didn't understand or she didn't understand? Was it explained in the right way? So I will encourage everybody that's watching this presentation to use interpreter services. You don't have to butcher Spanish. This is cancer care. It's very important to have an interpreter and to have a translator. Do not use family members because family members may not provide all the information. One of the solutions to the challenge is to increase the diversity of the workforce. I think it's very important that we stop being the researcher that you never see again. It means you go to the community, you investigate the disparities, and they never see you again. That leaves the community feel like they have been used. They came from the data they published and then they didn't help us anymore. I think a big gap is survivorship. Survivorship for patients with cancer that are Latinx is very limited data. And I think interventions that try to tailor to their activity is important. Having support groups and beauty salons, like you can see in these pictures. And I say it's time for intervention. We need to have meaningful actions, long-lasting relationships. And this is not only responsibility of the Latinx investigators or the Latinx physicians. This is a responsibility of us as a society to make sure we include everybody in clinical trials and that everybody is given equal care. I think it's important that we love each other, it's particularly in a very stressful time, and that we allow everybody to be part of the conversation. We published early this week, I think yesterday, this article about oncology training in Latin America. And I think I will invite everybody to take a look at it. It talks about the challenges that Latin America will be experiencing with cancer care outside of the United States and how the cases continue to increase in Latin America, or all cancers. And finally, I want to talk about the impact of COVID-19 in cancer care in Latinx. COVID-19 has been very challenging for populations of color. African American, Blacks, and Hispanics are most likely to get infected and also most likely to get complications from the virus. We have seen a high incidence, and there are many factors. The main one are those social determinants of health that we talk about it, and also is that many of our Latinx patients are part of essential workers. They work at groceries, they work in transportation services, they work in janitorial services in the hospital, in which they're essential to be in person, and they don't have the luxury to take a week off and work remotely. So why the goal of this talk is not to discuss COVID-19 in the Latinx population, it's only expected that there's going to be many challenges to cancer care in the Latinx population secondary to COVID. This means things are expected to get worse, and it's our responsibility to act on and help this vulnerable population. You are expecting to have delays in diagnosis. We are expected to have less treatment options. And it's also expected that they are less likely to be included in clinical trials. So the COVID-19 pandemic has only increased the challenges for this population, and it's expected that may widen the gap in cancer health disparities. With that, I would like to thank you all, and I would like to ask for your help. First, to provide compassionate care to all patients, and second, to understand the ethnic and racial difference that exists for patients, and to take into account that language barriers are real and that cultural differences are also an important part of cancer care. Well, thank you so much.